Good morning, everybody. We'll get started. We do have a visiting professor this morning, and I'll bring up Dr. Niesel here in a second to introduce Dr. Emory. The CME color for this morning will be black. And then we'll have a brief little resident session with Dr. Emory to follow. So Dr. Niesel. There we go.
So good morning, everybody. Dr. Mormon was not able to make it here today, so I am channeling my inner Mormon with a Duke cap here. Clearly, I'm not going to add another foot to my height. I think I'm okay on the shoulders, though. Also want to apologize to the House officers. Dr. Pat and I stole your time with Dr. Emory yesterday evening. And typically, the visiting professors will go out with you guys, but we had affairs of state to talk about with integration of Wake Forest. Dr. Emory also works in the OR, a job similar to mine. And she's also the interim chair of pediatrics. So you can only imagine the administrative things. So we had a lot to talk about. So she will have the opportunity to spend time with all of you, as the years move ahead when we continue with our integration. We did include in the Grand Rounds Planner Dr. Emory's CV and also just a statement about her. So I'm not going to go through that in great detail. Let's just say that, after leaving Chicago, the Chicagoland at birth, she made it to Georgia, had her schooling at Georgia. I believe she was at University of Georgia at the same time as Dr. Scannell, went to med school at Medical College of Georgia, Wake Forest for residency, and then University of Miami for her orthopedic oncology fellowship. She's also got an MBA, and if you read her CV closely, you'll see adjectives in there that sound like cum laude, AOA with distinction. So if you want to get engaged in a conversation with her, just get your facts straight, is all I'll tell you. So Cynthia, has been at Wake Forest quite a while. She immediately entered into leadership roles, which are many, and these fall along her interests, which are many. You'll see that she, as Dr. Hanley would say, is a member of all the appropriate societies, and she continues up the leadership rungs of those. So Cynthia serves as the vice chairman for the Department of Orthopedic Surgery there, and as I said, the interim chair of pediatrics. God bless you on that. And she's here today to talk about giving and receiving feedback. So Cynthia.
Good morning, everybody. Thank you for the kind introduction. As Dr. Niesel alluded to, I've been at Wake Forest for quite a few years now, joined the faculty in 2010, and really had a lot of early leadership opportunities. And along the way, I realized that there are certainly some skills that I would have wished I had acquired earlier in my years of training. And so today, I wanted to go through some of those things with you. So to start out with a question, and welcome to our folks who are joining us virtually. Who in here likes giving feedback? Any? 1, 2, 3? That's actually more than what I thought it would be. Who likes receiving feedback? Okay, quite a few of us. Maybe. Depends how it's given. Okay, well, good. Then it sounds like I picked the right thing to talk about today. So in disclosure, I run one of the leadership roles that I have is I run our PARS program, which is a patient advocacy reporting system. It's a program that was generated out of Vanderbilt that looks at a physician's risk of being sued based on unsolicited patient complaints. And so your information that goes to service excellence, whatever it's called here, gets entered into a database, and Vanderbilt has this proprietary algorithm, and they give you a risk score based on your specialty and based on the national average. So I started early in my career as a messenger through PARS, where I was the person to have that cup of coffee conversation with the person who was on the list and going through those complaints with them. So I use that as a disclosure here. Over the years, I now oversee that program, but this is sort of where I got some of my on-the-job training about how to give and receive feedback. I don't have any financial conflicts to disclose. So let's start with the why. Why do we need to give feedback? Anyone want to take a shot at that one? Why is it important? So we can get better, so we can grow, so we can figure out how to care better for our patients, so we can figure out how to talk to each other in a more collaborative way. Why is it so hard? Okay, we perceive feedback as something that's bad. All right, does that have to be the case? No, it doesn't. How come it's hard to receive feedback? When someone says, hey, I want to give you some feedback, anybody get that gut reaction? We're like, oh, what did I do? Yeah, seeing some heads nod and some smiles. Okay. So some of that's a conditioned response. You guys are all familiar with Pavlov's dog. And so I use that as an analogy here in the same context of, hey, I want to give you some feedback. And then you have that visceral response. You're already putting your walls up. You're already becoming defensive. And you're no longer in a place that you can be receptive to what the person has to say. They haven't even started talking yet. And all of a sudden your heart rate's up and you're worried about, oh my gosh, what did I do? Trying to think back to the past 3 or 4 days. Did somebody report me? Am I in trouble? What's going to happen? Sounding familiar? Okay. So that gut feeling can actually drive a lot of your reaction and your ability to shut down. So this is some of the easy stuff. If you want to give feedback to somebody, who here, if you had toilet paper stuck to your shoe, would want somebody to tell you that? You would. Anybody have trouble telling somebody that? Sometimes a little bit, but not quite as much. Same thing with having food stuck in your teeth. Right? Usually it's pretty easy to tell somebody, hey, you got to go take care of that thing when you smile, okay? And we would all want that information. That's desired feedback. Even though it's not positive, it's desired feedback. So what makes this different? Any ideas? Okay, it's objective and there's a common goal. Both parties want you're going to want that piece of toilet paper to not be on the bottom of your shoe. Both parties are going to want to ensure that your skirt's not tucked into your underwear when you come out of the bathroom. All of those very, very common kinds of things. And so that's what makes these easy. There's a common goal there. And it's objective, it's not personal. It's not attacking you as a person. And so that's the context of what we'll talk about today, is the way in which you can give feedback that it doesn't make it personal to generate that really visceral or that gut reaction response. So this is the hard part of feedback. When we talk about things like 360s and when we talk about surveys, this is the way that maybe a performance evaluation, right? We have an annual performance evaluation for all of our faculty. You have an annual evaluation with your program director. Hopefully you have evaluations more frequently than that. But perhaps at the end of the rotation, you may receive some information on your end of rotation evaluation that says, wished resident would have been more prepared for OR. And you've got nothing along the way. And so then you get these comments at the end of your rotation. You're like, what happened? I thought I was doing a really good job and I don't understand. And so that fills that cycle of the feedback in a way in which you're thinking, well, gosh, I don't really find this valuable. So I'm going to separate that out and I'm going to move it off to the side. And I'm not going to listen to it. I'm not going to take it in and process it. So that's the piece to try to work through. One of the problems with giving feedback is you feel like you're going to have to be the bad guy. I'm going to have to tell you that you're a bad person. And that's not really the case. These are specific things that we would like to see done differently. And keeping in mind how you can be objective about the way in which you convey that information can remove that personal piece from it. One of the challenges is there's a fear of retaliation. I don't want to be the one to give the bad news. Then all of a sudden I may not be liked anymore. That person may take it, they may hold it against me, or they may retaliate in some way. Even though you come from a place of being well-intentioned, You really want to impact the behaviors of that person down the road to make them a better doctor, to make them a better nurse, make them a better staff member, whatever, whoever it is that you're talking with. And so removing that emotion from it can be incredibly impactful. It's also really, really hard to do when you're walking into that conversation and either you're anxious because you're receiving feedback or you're anxious because you're the one who's supposed to be giving feedback, and neither one of you are comfortable with that situation. And a lot of times people struggle with the inability of how to give the message. Let's say you've got in your head, okay, I need to tell this person this particular thing. You know, they're condescending towards patients and they probably don't realize that they're doing it. I need to talk to them about it. And then you go and you have a conversation with your colleague and you say, Mike, you know, every time you're talking to these patients, you know, you're just sounding like you're arrogant, and then Mike gets upset. I don't know, I'm not arrogant, you know, and then all of a sudden the conversation de-escalates and then the whole point is lost. And so being able to find a way to communicate that information is very, very important. And we'll go through a few examples here. So I've talked a little bit about this whole concept of feedback, and the amygdala is where all of this stuff happens. So that's our emotional processing center. I'm not going to get all brainy on you guys or anything like that. But this is how we coordinate our stimulus response. So we take in information and then we process that information. And there's the pathways, and I'm not going to go into any of that stuff, but essentially we are processing lots of information all at once. And if we see facial expressions where people look angry or intimidating, we process that and then our body responds. We have a gut reaction to that. And so this amygdala hijack thing is a real phenomenon. And there's been lots of papers published on it and lots of different books published on it. It's an interesting concept. And this is when you perceive a threat, and that threat can be a bear chasing you outside, or it can be someone who is giving you some information that you don't want to hear and you perceive it as a threat. And so then you shut down. You have this triggered response. You're dismissing the information, you're putting up those walls and you're shutting down and not really listening to what that person has to say. Oftentimes, the way in which the message is delivered is causing that. And that's the piece that can certainly be moderated. So you also want to be aware of how long it takes you to go from having that gut reaction of this is really uncomfortable and I don't want to listen to this, to taking a breath, taking a pause, whatever it is, to, okay, I'm ready to listen. It may not be in that moment. If someone says, I have to have a difficult conversation with you, it's okay to say, I'm not in the right space to do that. Can we meet in 20 minutes? Or can we do this later today or tomorrow? It doesn't mean I'm not ready to do it ever, because you are going to have that conversation. But it's okay to say, I'm really not in a good space right now to have that difficult conversation with you. Can we regroup in a few minutes? And then walk down the hall, whatever it is, get a drink of water, do a breathing exercise, go outside and scream if you need to, come back in, then you're in a new place. So these are some steps of how to make it easy. And the easy piece comes with experience, which means you actually have to do it. You have to practice giving feedback, just like you practice all of your technical skills and you practice your diagnostic skills in the office and in the emergency room. These are things that are going to require some practice. You guys all have a great peer network. It is a low pressure system, and you guys can practice these techniques with each other. And I also encourage you to talk with the attendings with whom you're working with. And for the attendings that are with us, please ensure that you're practicing this as well, because this is nothing that most of us learn through our training. Right? We don't have as one of our core competencies the ability to have difficult conversations and give and receive feedback. We have, can you technically do this procedure? Are you able to diagnose this? But this is not part of our routine training curriculum, but arguably it's one of the more important things that you'll learn in your medical profession. So being specific about the behaviors, not saying you're a bad person, not saying you're not a team player. Those aren't really very helpful pieces of information. What does that mean? What you could say is the team feels like you're not contributing equally because you show up late for cases when the patient's already prepped and draped. That's a much more specific thing of this is the problem. And that's something that's actionable, so that and objective. And so that all of these things really kind of relate to each other. The objective piece, being able to describe the specific action and behavior, can be very important to remove the emotion from the conversation that you're having and can keep it even keeled. It gets you back to that common goal. Right? I want you to be a better doctor. And if this is able to be modified or changed or enhanced or whatever it is that you're going to be delivering, that's going to make you a better doctor. We have that common goal. We want to provide optimal patient care. So if you can help identify that common goal when you're having that conversation, certainly it can lower the emotional tension that goes along with having a difficult conversation. And you want to be actionable. When you're talking with people, you want to be able to, the example here, you need to step up and work harder. Well, what does that mean? Is that longer hours? What does that really mean? Versus these are the things that I noticed that you're not doing in preparation when we're seeing consults down in the ER. This is what I would like you to do instead. Right? So giving them very specifics. Medical students respond very well to actionable items. They really want to be helpful, right? And they follow you around because they really want to be helpful. And so if you give them something to do, they're so excited that they get to do something and be an effective member of the team. And how often do we actually take the time to tell them this is how you can truly be effective? Or this is how you're not being as effective as you could be, right? Giving them that feedback. Medical students are actually great about asking for feedback. And what do we tell them? You did a great job, right? Who are my medical students in here? How many of you have been told you did a great job? Okay. Did you find that helpful? No. It feels good, right? You're like, oh, that's great. Yeah, I did a great job. But it's not really valuable as far as how can I become better, right? We want them to become better doctors than their current state of training. So take 2 minutes to go through a debrief. When you're holding that leg for a splint down in the ER, we're going to hold them by the big toe and support under the calf and bend the knee. And here's why we're bending the knee and going through all those different things. Or I didn't like how you put the mold on this particular splint because of this. Here's what I would do differently. Those types of very small pieces of feedback can be really, really critical. You know it, but don't necessarily assume that the learner who's with you does. So those are just some very specific, tangible things that you can go through. And for the medical students, this is a two-way street. When you ask for feedback, be a little more specific. Feedback about what? Right? How did I do in that case? Did you like the way in which I positioned the retractors? Was I appropriate with the way in which I was interacting with the team? Ask specific questions. It's okay to be specific. It's easier to be specific than have these vague terms of, how did I do? You did great. Okay, that's not very helpful. Make sense? And then the timely piece. When you're giving feedback, whether it's good feedback or bad feedback, making sure that you're doing it in the moment and not the, oh, hey, you remember last month when that nurse wrote you up because you weren't being professional? We need to talk about that now because it's come up through some committee and I'm supposed to talk to you about it. And so if the event is so far removed, and sometimes your emotion and your emotion can impact the way in which you recall those events. So in general, there are two sides, at least, to most versions if there's conflict. And your recollection of something certainly can be less accurate if it is tied with a lot of emotion. So having that very specific, actionable, and objective conversation in a very timely manner is helpful. For instance, when I work with residents in the operating room and medical students, when we're closing a case, now I do tumor, so we have these big incisions and you have to have something to do during the closure. We go through with the residents and I start with, and it's just the 2 or 3 of us there at the table. What went well? What did you learn? And what would you do differently? And I ask the resident that almost every time. And so when I ask the resident to do that self-evaluation, that self-reflection, I'm able to learn, okay, did they think that that case went well? And did they actually learn something from it? If a resident walks out of the room and is like, that was the best case ever, I totally nailed it. And I'm walking out of the room going, oh my gosh, that was such a disaster. That's not really very helpful if we don't talk about the difference and the disparity, right? And you guys are smiling because you've all had that, right? And we may not share that with you, but we should. We should, right? It is our obligation as attendings to ensure that if something doesn't go well, that we go through that with you so that you don't process that in your brain of, wow, that was a big win. Because if it wasn't, you need to know about it. And so then the residents and the students will do this too. After I get a chance to hear what went well, what they would do differently, what did they learn, then I go through that same process with them. And it is while we're closing, so we have something to do. It's not this sit down, very formal kind of thing, and it takes about 3 or 4 minutes. And I will say, okay, I really liked how you broached the hip for this particular fracture that we did, or I thought that you maybe were a little bit too aggressive given that it was osteoporotic bone, and I was worried that you might have fractured the calcar, or here's what I would suggest that you do differently. So something that's very specific to that case. And then I can take that information, and that person can take that information and apply it in real time to the next case. So yes, we do mid-rotation evaluations, we do end of rotation evaluations. That's a summative evaluation of all of the little pieces of information that we've been talking about along the way. So there's no surprises. Many of you may have gotten end of rotation evaluations before and thought, well, gosh, I really wish I would have known this earlier, because now I can't change anything. I'm on to another rotation. And that can be really frustrating for learners. And it can be frustrating for faculty too, because we're sitting there and we're thinking, gosh, I really wish they would have done something differently this whole time. And they've been on this rotation for 2-3 months and they didn't really change anything. Well, did you talk to him about it? And that's really kind of the easiest thing, is just to have that conversation. So I tried to give some recommendations for the surgeons in this particular way in which to give feedback. If I were to give this lecture to pediatricians, I would probably change this slide, but consider it like a pre-op plan. When you prepare for cases, you've done your reading, right? So you're knowledgeable about what happened or what's going to happen. You have a plan of how you're going to set things up, and you have a plan of how you're going to execute, and you have a plan of what the follow-up is going to be, right? If not, you should, and that's a whole different conversation that we'll have. So how you give and receive feedback can be approached very similarly. You want to have a plan. If you need to write out what you want to say, especially as you're just learning how to use these tools and how to do this, that's perfectly fine. When you practice with a colleague, say, I'd like to actually practice this with you because this is an area where I struggle. It's okay to say that. It's okay to be a little bit vulnerable. It makes you actually a little bit more personable and more likable. Now, I am a person who doesn't overly share, so I recognize that's a hard thing to do. But it's okay to tell somebody, I'm not really very good at this and I want to get better at this. Will you help me? And they'll either say yes or no, and that's fine. You have your answer. And so you either can work with that person or you can find someone else to work with. You can write down some notes of some things so you don't forget, especially if you're nervous going into having this conversation. You can jot a couple things down on a note card so you make sure that you address all the points you want to talk about. Make sure that you're keeping an even tone. If you need to take a couple of breaths as you're going through and giving the information, it's okay to do that. And then also think about, what are the assumptions that you're making? Did you do your fact checking before you're going to have a conversation, especially a difficult conversation with somebody? Because oftentimes inaccuracies in information can lead to an escalation pretty quickly, and then the whole conversation gets derailed. And then think about, are there any other alternatives? Is the best way to convey that information a shouting match in the hallway in the ER with the resident? Or is it perhaps better to have that person come aside and say, we need to talk about this. We have an issue here that I'm concerned about. So these are a couple of examples. So let's say you have a resident that's going to be coming up and giving a talk. All right. And it's a scientific talk. So you've got your key point listed here. This is an example of a resident slide. So this text is written out, enabling the resident to read the slides to the audience verbatim in too many words on the slide, and thus losing the impact of the point of the slide. In addition to the rapid speech and run-on sentences, there are multiple studies quoted during the talk which show the resident did an exhaustive literature search and can regurgitate the information to the audience, but wasn't actually able to capture the salient points of the literature search and distill it down to the most critical pieces of information and convey that to the audience. The resident also adjusts the font to something so small to get a ton of words on each slide and avoids any white space. There are also several figures that are too small for anyone in the audience to see, and the resident apologizes for the charts being too small, but includes them anyway in the talk with the standard red ring to highlight something important that you can't read. You also notice that the resident has 40 slides for a 15-minute talk on the assigned topic, and there's no way they're going to finish on time, so they just talk faster to get through all the slides. Sound familiar? Anybody done that? I have. Okay. So how are you going to approach giving a resident feedback on their slides? Who has some suggestions? If you don't tell the resident anything, they're going to think this was I killed it. I totally killed it. Got through all my slides in time. I can even add a couple more for next time. Right? What are you going to say? Okay. What were your goals? So finding that common goal. What did you want to convey to your audience? And that's the first piece when you're putting a talk together is what do you want to convey to your audience? And if you go through your talk and you get to the end of the talk, ask yourself, did I convey what I intended to convey to the audience? And if you can't answer that question, it's probably no. If you don't know if you conveyed your stuff from your talk, chances are the audience didn't get it either. So you can break it down into themes. And this goes into that specific, actionable, objective, timely kind of thing. So you want to have a conversation with a resident relatively soon after this talk was done. And maybe you can break it down into buckets. You could look at content. Okay, you had a lot of information in your talk. It shows that you're well read and researched. Did you need to put all that information in the talk or maybe have as an appendix or a pocket slide if someone were to ask you additional information about it? Did you really reinforce the salient points? Maybe those 2 or 3 key points that you wanted to convey to the audience at the end. Did you address any controversy? Was the topic that you're talking about, are there disparate ways? Are you talking about clavicle fractures where we can't really decide what we want to do with clavicle fractures, for instance? Then you can look at another bucket of style. The font was maybe a little bit too small for a lot of the people in the room to see it. And so the message that you wanted to convey through your text was lost because people couldn't read your words. There's also too many words on your slides for people, and they got lost with trying to read the slide and weren't able to listen to you instead. And so that's very specific feedback. And it's not saying you're a terrible person, you did a terrible job with that lecture. It is, these are some things that really could be improved upon to make you more effective as a speaker. And then making sure that you have the balance of the background information. These are just some examples. Okay, so you kind of get the idea of how you can approach a topic such as that. And that one's a fairly easy discussion. It's less controversial. Don't forget to include positive feedback. I liked that you were well prepared and that you finished on time. Okay, but be cautious with this. You don't want to say, well, I really like that you were well prepared and then give them all this stuff about how it didn't go well and then say at the end, but you finished on time, right? That's that feedback sandwich thing that I personally don't think is a good idea. What happens, in my opinion, is when you start with something that's good and you're going to put something bad in the middle and then end with something that's good, you start the meeting on a positive note, you end the meeting on a positive note, and then the person leaves the room and says, well, did I do it right or not? So it's conflicting information. It also sets the tone when when that person comes back and says something nice, you're waiting for the other thing. Right? You're like, oh, okay, yeah, see, this is what they do every time. They're going to come say, oh, I really like your shoes. And then they're going to come tell me about how I did something else wrong. And so then it sets the tone of maybe from a less genuine perspective. So this is an example of a feedback sandwich. Let's say you're doing informed consent on a patient. Your discussion of the alternatives to the procedure was well organized and detailed. You missed an opportunity to discuss the risks of the procedure with the patient. You described the steps of the procedure very well. So then you walk out of the room and you're like, so do I keep doing that? What do I need to do differently? And so you can see how that can maybe send a confusing message to the person and can cloud the true intent of what you wanted to come across. Now you can go through the list of here are all the things that you did well, and here are some things that I think that you can improve upon. There's nothing wrong with that, but I would not approach a conversation with the intent of sandwiching the bad stuff in the middle. Just my 2 cents. Some people like that. So I've touched on a little bit of this. The pros, it does soften the impact of the criticism. If you have somebody perhaps who doesn't receive negative information well, this could be a starter to start having those conversations with them. Again, I personally don't think it comes from a place of being truly genuine, and it makes the overall message less clear. All right, we have another case. This is Janice. She's been an OR nurse at CMC Maine for 25 years. She's got one speed and it's not fast. This is the way that it's always been. So she has no desire to change anything because this is how it's been for 25 years. You guys all come and go. But she's been here for 25 years. So she's not necessarily open and receptive to change. So you're here, you got a new joint person, and they want to do all this robotic assisted stuff in the OR. Mysteriously, all these trays keep getting contaminated every time when Janice is in the room. And we can't use the robot time and time again. There's always a reason. Parts are missing, stuff goes missing, can't get it to work right. Things always happen that you can't use the robotic assisted surgery. So how are you going to approach this conversation with Janice? What do you think? You want to do it in the middle of the case? When you're frustrated that you can't use your robot again, you got this brand new $1 million robot that's sitting over there all nice and shiny and you can't use it. Dr. Mormon's going to get upset. You're not getting the margin on that case. You could take her out to dinner. Okay. That could be a bit of an awkward conversation unless you know Janice very well. Maybe suggest a cup of coffee instead, so that if it de-escalates, that you're not stuck at having a meal with that person. So it suggests maybe having a cup of coffee, because you can drink your coffee slow, or you can drink your coffee fast. You could take it to go if you need to. So maybe having a cup of coffee with Janice. Janice, there's something I wanted to talk with you about. I'm concerned that, and then you can state what you want to say, right? I am concerned that when we're trying to do robotic surgery in the operating room, we're not on the same page here. Why are we not able to get these cases done? Help me understand, right? That's a great leading discussion. Help me understand what your concerns are about implementing this new technology in the operating room. There may legitimately be reasons why trays keep getting contaminated or pieces get missing over and over again, but really think about how are you going to approach that conversation not as a Janice, you are sabotaging these cases every time, so we can't get them done, right? That's going to be the amygdala hijack, where she's all of a sudden going to shut down. She's going to get defensive, and then they start pointing out some faults that you have. If you approach it differently and say, Janice, can you help me understand what your concerns are about implementing robotic technology? Just leave it open. See what she has to say. It may be an education piece. Maybe she doesn't feel comfortable on it because she hasn't been trained well enough. She may be concerned that she's going to be replaced by something that's robotic with the implementation of technology, right? You don't know what her reasons are unless you ask. And so that's a great way to approach having that conversation with her. One more case. Dr. Ortho. Dr. Ortho is a well-established surgeon. He's in his early 50s. Dr. Ortho throws things in the OR when things aren't going well. Yells at the staff if turnover is more than 20 minutes. There's multiple complaints from the clinic staff regarding mistreatment, throwing stuff in clinic, yelling at people. How are you going to approach this conversation? We don't know any Dr. Orthos. This is totally hypothetical, okay? We probably don't want to go out to dinner with Dr. Ortho based on what we're hearing, but how would we approach this? And this is, unfortunately, this is not an uncommon scenario.
The presumption for the people in the room here is they might be subordinate.
Exactly.
Feedback.
Right.
Right. So I think that's the question for this one, because it's a different question to me.
Right.
Okay, so that's just going to frame the question.
Yeah, absolutely. How do you do this in a hierarchical situation? If this is your attending, what are you going to say? You're going to run over to Dr. Scannell and say, Dr. Scannell, we need some help, right? So there is a way that there is a way that you can have a crucial conversation with somebody, even if you're in a hierarchical situation. again, keeping it, just distill it down to those very basic core things that we've talked about today. Make it specific. Dr. Ortho, Mary in the office today was tearful after she was being yelled at for not bringing patients back fast enough, right? I know she's working as hard as she can, but she just broke her foot 10 weeks ago and she came back early because she didn't want you to be by yourself, right? Those kinds of things of, there may be some not realizing on behalf of Dr. Ortho, the impact that Dr. Ortho is having on his team or her team. This can be a woman surgeon too. And so one way to describe the behaviors, not saying you're doing this wrong, you're doing that wrong. You can describe the impact that that action is having on the recipient. They really can't argue with that. I feel bad when I'm getting yelled at in the operating room for X, Y, and Z. And they can't really argue with the fact that you feel bad. That's how you feel. That's the truth. And so you can describe the impact that an action or those words or those statements have and say, is there a way that this can be done differently? And that's at least introducing the conversation. Most of the time, having these really difficult conversations is a starter and then multiple subsequent conversations. And certainly you want to have your supervisors involved. I'm not saying that you need to go to the chair of surgery and say, hey, you know, this is not acceptable and this is the conversation we need to have. I'm not asking you to be pioneers with this. But it doesn't, being a learner does not mean that you're not also responsible for the productivity of a team and the efficiency of a team and building a team. And that's a piece that I think, especially as students and residents, that you have the opportunity to voice a concern. You can also voice something that went really well. It's okay to do that. And I would encourage you guys to do that. For some of the other things that are on here, when you're having conversations with peers, it is important to outline, these are the behaviors that are not acceptable, and being very specific with these are the behaviors that were relayed to me and verifying that that's actually what occurred, and saying, these are the expectations, that this needs to be changed, that needs to be changed. And these are the consequences if those expectations are not met. And that's a piece that I think oftentimes leaders struggle with, is making sure that there's the follow through on what those expectations are and the consequences. That's really the key thing with Crucial Conversations. It's a good book if none of you have read it. Yeah.
So my 2 cents on that, this situation, the behavior described, but for everybody in the room, particularly for the subordinate, that sentence is focus on you personally. To sit there and say to that person, the doctor, act when you demonstrate those behaviors, serum and research back, myself, whoever's the target, focus on our response to you, focus on the patient, and don't you want us to focus on the patient and the outcome of the patient and the patient, because that really gets to the heart of the matter very, very quickly, and depersonalizes it from them and depersonalizes it from you. So, you know, it's like, yeah, you're a baby, and can't take it, can't take the heat, come from the kitchen, and it takes all that off of you. And quite honestly, that's actually the biggest point. You know, serve that student, and all she's thinking about is this guy's going to chew me up with the whole face. They're not going to focus on the case, and they're going to make a mistake.
Yeah.
So I think that's a super easy sentence to remember, because everybody in this room is going to face that, you know, in the next few months. Yeah.
Absolutely. Yeah. That's a great point, is to bring that conversation back to the common goal, which is how can we provide the best care for our patient that's here with us in the operating room. And when you probably have scrub tech students, you probably have nursing students that are in the operating rooms with you as well. And if you think back to when you were a student, or for those of you who are currently in that spot, you really are thinking about, how can I just not screw up, right? And you kind of miss some of the things, the opportunity to learn on the case. My piece of advice would be just kind of relax a little bit and really try to focus on the case. It's okay to ask questions. Why are you doing this? Why are you doing that? If you get asked questions and you don't know the answers, it's okay. You don't have to perseverate it on for the whole rest of the case, being like, gosh, I can't believe I missed that question. I knew that. But you're missing out on the opportunity of all the other stuff that you can learn. And for the residents who are working with other learners, and whether they're nursing learners or anesthesia learners, having a conversation at the end of the day, hey, let's talk about today. You have nothing to lose. You can get their feedback, they can get yours. You can start building that social capital, which is a whole other different talk that that's a skill that you're also gonna have to learn. When you're a junior resident, you spend time building social capital with the nurses. So when you're a chief resident, you really got to get that case done. You can call up on that social capital to try to get that case going at a faster time versus if you're the guy or the girl that, that has been unapproachable through all of residency, and then you're trying to ask for a favor by the time you're a chief resident, that's not going to happen. So that's a very important thing, is to make sure that you're having that constant feedback. So there can be lots of false starts, and what to do if you've had a false start. Let's say you've tried to have a corrective action discussion or a difficult conversation and it has gone horribly wrong. Okay. Maybe yelling, throwing, walking out, whatever it is, did not accomplish. You walk out of the conversation, you think, well, this didn't go at all like how I had planned. And so then you think, well, how do I reframe that? I still have to be able to convey the message if I don't feel like it was effectively delivered. And then do that debrief. What didn't go well? Why didn't it go well? Maybe talk about it with a colleague. Here's the conversation we had. Here's where it got derailed. Help me understand where did I go wrong? Was there something that I did? And then follow up with the person that you were talking with. I'm sorry that this conversation did not go well the other day. It doesn't mean you're wrong, I'm wrong. It is, I'm sorry that we had a bad outcome. Can we find a time to talk about this again? And the worst that happens is say no. And then you have to figure out, maybe is it involving someone else or approaching them at a different time? It's okay to be vulnerable when you're having these conversations. I feel like we didn't get a good resolution to the discussion that we had the other day. It's okay to say that. So not all feedback is the same. Most of us are familiar with summative feedback, meaning you get your end of rotation evaluation and it has a list of things. I did this, I did not do this, I did this well, that Likert scale stuff and some comments. The formative feedback, I think, is actually much more impactful. And that's that real time as things are going along. How'd you do in clinic today? Were you efficient in clinic? Did you miss key findings, right? Was Mrs. Jones hemoglobin 6 on her follow-up and you didn't mention that because you didn't look in the labs? Those kinds of very specific items, those are things to be thinking about going forward. So I'd encourage you to implement formative feedback into your daily routine. And it's only just a matter of minutes. And there's a lot of power of learning from your mistakes. Most of you will make a mistake in the operating room, I promise. And those are the ones you learn from. Very rarely do you really remember the case that just went splendidly and it was perfect and there was no issues at all. But when you put that stem in varus, or when you missed the start site and you couldn't get it for 25 minutes, those are the things that you remember. And that's the stuff that keeps you up at night. Yeah, and you have to think about, well, how can I do it differently next time? Not only does it help you get over that, but you learn from it. And so we learn from our mistakes, and it's okay to talk about those things. Everybody in this room makes mistakes and we'll continue to do them. It's an ongoing learning process. So some final thoughts: that this is hard. Being able to give feedback, being able to receive feedback does require a bit of vulnerability, requires some skill, it requires some practice, and you get better with it over time. So you need that experience. And that's not something we want to get good at something right away and then just be good at it. And this is giving and receiving feedback is not really one of those things. It's a work in progress. So I would encourage you to not just try it once and say, oh, that's not for me, I'm just not going to do it. It's going to take some time and some practice. Knowing what your processing time is. If you're having that amygdala hijack, if you're having that visceral or gut reaction, to think, okay, I'm going to need a little time out here. I'm going to go get a cup of coffee. I'll be back in 3 minutes and then we can talk. That gives you that chance to calm things down a little bit. And then really remember to employ those key things: making something specific, making something actionable, and then objective, and thinking about what that impact is going to be as you're giving and receiving feedback. Really try to remove that emotional context with saying, you do this or you're not doing this, instead describing the impact when you're late for the case is such, or however it is that you want to phrase it based on what you want to talk about. So really try to remove that emotion from it and just be as specific as you can. So I think we have a little bit of time for discussion or questions.
Hey, this is Jenny Casey. I'm sorry I'm driving in. I'm a pediatric orthopedic surgeon here, and I think I have a similar role in terms of medical director and head of PARS and kind of all that. And I'm really grateful for your talk this morning. I think it was fantastic and timely. And you're right, we don't get this education. And in fact, at Ortho Carolina, we're starting this education with a physician curriculum, including kind of crucial conversations and these kinds of things for our shareholder track physicians. So I just wanted to commend you. And then my only other comment was, and I put it in the chat, but I don't think anybody's in the chat. Sometimes I think the difficult conversations is about behavior that's not concrete, and you alluded to this about feelings. And so I like to use the phrase of you are being perceived this way, and for whatever reason you're being perceived this way, and just asking people, is that how you want to be perceived? And then if they say no, well, then you can work together on strategies of how to fix that problem. If they say yes, that's a different issue altogether. But I just thought that was one other tidbit I'd mention.
That's great. Thank you, Dr. Casey. I agree. When you're having those tough conversations with people, being able to relay, I've talked to a couple of other people, or I have heard concerns from other people, and this is how you are being perceived, that can be very impactful. Certainly, it's a whole different problem if that is the intent, but by and large, people are good people, and they don't want to be perceived as a whatever it is, as a bad whatever. And so that I think is really important. Other questions or comments?
Thanks a lot. That was a great talk. I really appreciate it. I have a quick question. The framework you gave for the feedback session seems like it puts maybe a little bit more, maybe this is just natural, but the onus on the person giving the feedback to set the structure. Any advice you have for the learners in the room if they are in a feedback session with somebody who might not have been exposed to this material, how the learner can try to steer the structure in that direction, maybe set those expectations. It often feels difficult to do that when you're in the receiving end. Yes,
I think I appreciate that question. I wrote a little bit about this in CORE, and I can send that article maybe to Dr. Niesel. It's one of those like short little letters things, so it's not a bad read. If you're approaching a conversation and let's say it's time for your end of rotation evaluation, and you're walking into this end of rotation evaluation, you think, oh, this, I've heard how these go. These really aren't going to go very well. You have a couple of options. If you know when that date is going to be, you can send some questions, very specific things ahead of time. In our end of rotation evaluation, I would like feedback on the following things: my start site for nails, the way in which I prepared a femur for a hip, the way in which I interacted with patients in the office, my summaries and presentations of patients when we saw them in the office, whatever it is. You can have a list of maybe 5 or 6 things to kind of get started. You don't want to send a whole list of like 25 things. So maybe pick your top 5 things that you really are interested in their opinion of, I'm not really sure how this is going, or I want to get better in this space. And so these are the 5 things I'm going to talk about. Send it ahead of time. And hopefully that person will receive that and think about those things and prepare to have that conversation, kind of help tee things up, so to speak. If you're in a situation where maybe you haven't had the opportunity to do that, and they say, well, gosh, you did a great job on the rotation. Thank you. I really appreciate that. Can you give me some specifics? What were some of the things that you liked about what I did? And it's more that follow-up question. If you're getting a vague answer, well, tell me more. It's that 5 whys kind of thing. Well, why did I do a great job? Well, you're really good in the OR. Well, why was I good in the operating room? Well, and that it's kind of, I mean, a little annoying, but it's okay. It gets you to the meat of the thing. And then at the end of it, say, thank you. I really appreciated the specific things that you were able to cover with me. That helps me understand the things that I'm doing well. Can we also talk about some things that you think I could improve upon? Sometimes it's really hard for people to give negative feedback. Everybody wants to be supportive and all this, especially in this whole era where everybody's burned out about everything, but nobody wants to say anything bad. One, because they're worried you're going to quit, you're going to, go off the deep end, you're going to get written up. And so people seem very hesitant to have difficult conversations nowadays. And I think arguably now when tensions are pretty high and people are stressed, it's really more important to have those conversations instead of just letting something fester. And so maybe starting with some of the things that went well, maybe the easier part of the conversation, and then trying to say, if you have a few minutes, I really like to talk about some of the specific things that I can do to improve on my future rotations. That's what I would say.
You touched a little bit just now. One of the questions that I had, just to kind of follow up on what Samuel had asked, I think in GME, we do a pretty good job of summative feedback, and probably almost too much summative feedback and not enough of the formative feedback. How can, we're all, no matter what center you're at, we talked a little bit about this on the way over, of just life is busy, practice is busy. Faculty are not always great at kind of giving that regular formative feedback. You touched a little bit just now, but any other tips for residents on sort of how to set up that formative feedback discussion, sort of on a, whether it be daily, weekly basis? You talked throughout your talk on OR situation, but I think probably the piece we don't get as much is maybe in the clinic setting.
Mm-hmm.
So maybe some tips for the residents as far as how they can sort of take ownership of that receiving of feedback and the formative feedback in that setting.
Sure. And we all know, the goal of clinic is to finish, right? That's the goal. No one has ever not been successful with that goal. So clinic is not the time that you really want to just kind of hang around and talk about stuff, right? You're in and out of rooms, you boom, 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 you got 40 patients to see, and it's all of a sudden you go into efficiency model. And it can be very challenging to remember that you're in a learning environment. And so taking those key points, I do this debrief at the end of clinic with the residents too, is I run the list with my nurse and we go through like, okay, this person needs this and this biopsy and all that stuff. And then I talk with the residents. Okay, we do the same thing. Tell me 2 or 3 things that you learned today based on the patients that you saw. And that's 2 or 3 minutes. And then I go through, I liked the way in which you documented the imaging findings on this particular patient, or I did not like the way that you documented these imaging findings, and here's why. Here's what I would do differently. Or you can take that opportunity to give maybe a small little talk on coding. The way in which you enter the ENM is not supported by the documentation that you provided, and here's why. So those are just some very concrete examples of just some small things that maybe take 2 or 3 minutes. From a resident generating standpoint of how can I get these conversations going? Because at the end of the day, they're gone, right? As soon as the last patient's out the door. Maybe set the tone or at the beginning of clinic and say, at some point today, either during, maybe at the end of clinic, I'd like to take about 5 minutes and go through these 2 things. I'd like to understand how you describe your imaging findings or why you do it in such a way, or I'd like to understand more about your medical decision-making in the way in which you document for this patient for total joint. So try to be very specific from that standpoint. And again, as teachers, you make time in general. This is a good life principle. You make time for things that are important. And the 2 minutes is worth it to do it, to make you a better doctor.
Any other comments or questions? All right. Well, thank you, Dr. Emory.
Thank you.
We'll take a couple-minute break and then we'll get started.